right. Good evening, everyone, and thank you for joining our BPH webinar overview of treatment options. We'll start with just a few housekeeping items, and then I'm going to introduce our speaker. First, your attendance tonight is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself, the speaker, and our other host. So if you wish to ask a question at any point during the presentation, please move your cursor to bring up the chat box at the lower portion of your screen, and we will try to answer as many as we can at the conclusion of our presentation. The presentation tonight will last for approximately 1 hour and will be presented by urologist Dr. Justin Cohen of UroPartners LLC. Dr. Cohen is a board-certified urologist who practices all aspects of general urology, including BPH, minimally invasive stone treatment, vasectomies, prostate cancer, and Da Vinci robotic surgery. He's passionate about providing the highest quality personal care to his patients and serves as the chief compliance partner for UroPartners LLC. He also sits as the president of the Advocate Condell Physician Partners Board of Directors. In these roles, he contributes valuable insights regarding patient engagement, quality improvement, and cost effectiveness, and about the roles of specialists in population health. After graduating magna cum laude from the University of Illinois at Urbana-Champaign, Dr. Cohen attended Yale University School of Medicine, where he earned his medical degree cum laude. Following that, he completed his residency in adult and pediatric urology at Yale New Haven Hospital, where he also served as chief resident and received the Oss Foundation Research Award. Dr. Cohen primarily practices in Grayslake and also out of Libertyville and Pleasant Prairie, Wisconsin. Dr. Cohen lives in Lake Forest with his wife and 2 children, spending his free time cooking, cycling, and playing with his kids. So Dr. Cohen, thanks so much for joining us tonight. I'll turn it over to you.
Well, thank you, Jack. So first of all, I want to thank Boston Scientific for organizing this. The voice from above right there was Jack McNeil, and Scott Agastelli's on, and thank you guys for helping with this. I really want to thank everybody for joining. I know it's an evening. There's a lot of things you could be doing. I just appreciate your time. And, I'm sitting at home and it's kind of like a fireside chat. The one good thing about this, as opposed to being in my office at work, is nobody's going to have any rectal exams today. So that's good for you and for me. Today, I want to talk about the prostate, basically what it is. It's funny, we always talk about BPH, but nobody ever talks about what the prostate is. Then we'll talk about BPH and enlargement of the prostate and some of the symptoms. And then we'll talk about treatment options from watching and dietary modifications all the way up to surgical interventions. So I hope you find this interesting. Please feel free to type out any comments and questions, and Jack and Scott will be able to read those so you can get your questions answered as best as possible, obviously with the limitations of this format. First, we'll talk about the prostate. So what is the prostate? The prostate is a small gland. It's in many cases the size of a walnut. In the cases in my office, sometimes the size of a few walnuts, and it sits at the base of the bladder between the bladder and the urethra. So all the urine goes through the prostatic urethra. What does it actually do when you're younger? It produces fluid that helps to transport some of the ejaculatory fluids, the semen, the sperm. It helps actually condition the sperm to be a little more potent. After your childbearing age, all it serves is to cause cancer and to cause urinary issues. Those urinary issues frequently begin to show themselves in the 40s and 50s, and by the 60s, it's a lot more prevalent. Like I said, what can happen to it after you're done using it in your 20s and 30s and maybe 40s? It can become enlarged. You can get cancer, or you can develop a condition which is either infectious or inflammatory called prostatitis. And each of these, while different conditions, can have some overlap in terms of the symptoms. BPH is an enlargement of the prostate, a benign prostatic hyperplasia. So benign meaning non-cancerous, prostatic meaning of the prostate, and hyperplasia meaning more and larger cells. So the prostate can grow significantly, and normally it starts at about 1.5 inches in diameter, and certainly we do ultrasounds and find prostates that are 3, 4, and 5 inches in diameter. And as it grows, as we look at that initial screen, it can cause obstruction to the bladder outlet. So we'll go to some more anatomy in a little bit, but I just want to talk about some things that BPH is and things that BPH is not. First of all, it's not prostate cancer. So having an enlarged prostate and the urinary symptoms, as long as you're being screened properly for prostate cancer, could mean a completely non-cancerous condition. So we have a lot of misunderstanding sometimes that, a bigger prostate will lead to more prostate cancer or less prostate cancer, but they're two non-related entities. Like I said before, though, the symptoms can be similar to those of cancer with the obstruction. As the cancer grows, it can cause obstruction, just like as the prostate grows in a non-cancerous way. So you can have one, the other, or both. So it's important to evaluate everything as we're going through this process to make sure that we're not treating an enlargement of the prostate when we really need to be treating cancer of the prostate. You all probably have your PSAs drawn and rectal exams. As we all know, PSA is prostate-specific antigen. It's not cancer-specific. So we do use it as a screening test for prostate cancer, but having symptoms of enlargement and an elevated PSA doesn't necessarily mean you do or do not have prostate cancer. So as we showed briefly on the other slide, and more importantly on this slide, in this middle drawing, you have a normal prostate. So the bladder stores urine. When you have to urinate, these sphincters relax and the urine goes through the urethra, which begins in the prostate, and then out of the body. And we're going to use these beautiful male models today, given that we're talking about the prostate. I'm sorry for the graphic pictures for some of you here. In an enlarged state on the right here, you see that the prostate, when it tries to push the urine through the urethra, as the bladder pushes the urine through the urethra, as the prostate gets bigger, it makes that urethra more narrow. And when the urethra is more narrow, initially the bladder compensates. It's a muscle and it just squeezes harder. But over time, it either loses the ability to squeeze any further, or it's become a little bit bothered itself and diseased itself from having to work so hard over time. And men develop some urinary symptoms. Now, it's interesting to see when you see a really big prostate, you would think, of course, it's got to have more symptoms than a moderately enlarged prostate. And it's not always the case. Sometimes we have guys with giant prostates without symptoms and guys with prostates that are maybe 15 to 20% larger than it should be, which are causing symptoms. So, it takes a careful evaluation to see if the size of the prostate and the urinary symptoms are correlating and if we can improve things that way. So the symptoms of BPH, smile if you recognize any of these. In the middle there is weak urine flow, and that's often one of, if not the first symptom people get. And they typically get that initially at night when the bladder is asleep, like all the rest of your muscles, and it tries to empty itself, but there's a little bit of resistance and it just can't lift that extra weight very well. And so you have a weaker stream at night. That can also lead to some difficulty starting and stopping. And at the end of the stream, you can have some intermittent flow. Frequent urination, both during the day and the night. And one of the common symptoms is waking up at night, which is frequently due to enlarged prostate and could be due to other things as well. And then the daytime frequent urination and the sudden urge to urinate during the day can develop. And those are often signs that not only is the prostate enlarged, but now the bladder is having trouble compensating and overcoming that. Some men develop some burning and painful urination in some very late stages. And something that's actually relatively common is the inability to feel that your bladder's empty. So you pee and you're like, there's got to be more in there. I just can't get it all out. And that can be frustrating to a lot of guys. At the bottom right with the leaky faucet, they're talking about urinary retention where you can't empty your bladder at all. And that's kind of a more end stage issue. And that, you'd have to go to the ER and get a catheter in. And we'd like to avoid that. And traditionally, we've kind of waited to treat symptoms because the options that we had to treat the urinary symptoms were a little bit more invasive. So we waited a little bit longer. Now that we're getting better techniques that are less invasive, we can treat people a little bit earlier on so you don't develop some of the bad symptoms and don't have to live with it for as long of a period of time. Now, BPH is common. So 51% of men with BPH say it interferes with their life. It affects your partner's life. If you're getting out of bed to pee 3 or 4 times a night, you're waking up your spouse who's laying in bed with you potentially. It affects your daily routines. If you have to look for every bathroom in every store you go to, you're going to choose not to go out as much and do as many things as you'd like to do. And when you're there doing it, you're not enjoying yourself. You're not able to fully relax at Home Depot and pick which drill you want to get because you're constantly thinking that the bathroom is so far across the store. Up to 95% of men with moderate symptoms are unhappy and they don't want to spend their life living with the rest of these symptoms. And so, we're men, right? We frequently don't tell anybody what's going on and that something's bothering us. And then when we do, and somebody says, go to the doctor, you say, okay, I'll go there eventually. And, a couple of years later, you look back and you said, oh, I haven't been to the doctor yet. I maybe should go now as symptoms are progressive. But these are things that we need to talk about and things that we can help with. And if you're not happy, let's work on becoming happier. Anybody can get BPH. Any man could get BPH. It's the most common prostate problem for men above 50, obviously much more common than cancer, luckily, and much more common than infection. But by age 50, half of men will have enlargement of the prostate. And by age 85, almost everybody, 90% of men have enlargement of the prostate. Now, things you can do to improve the chance that you won't get BPH, you can work out more. People who are overweight tend to get more BPH and more symptoms. And part of that's due to the abdominal girth pushing on the abdomen and pushing on the bladder. Exercise can help as well. It can increase blood flow and it can improve the bladder health. It's a common problem. You're not alone with this though. As many as 14 million men in 2010 had symptoms, and I'm guessing it's probably even higher today. So, this is something we need to talk about. We need to get better and make our quality of life and the quality of life of our family and friends that we hang out with significantly even better. So how do you get diagnosed? First of all, you probably know it if you have it. You'll have some weak urinary stream. You'll wake up at night most of the time. Frequent urination, urgent urination, those symptoms that we talked about. But just having those symptoms doesn't mean you have an enlarged prostate. Again, we want to make sure that you wouldn't have prostate cancer or something else masquerading with these symptoms. Diabetes can cause frequent urination. So it's important when you get these symptoms to see your doctor. Most people see their primary care doctor. And a lot of what we do that goes into this diagnosis is the history. So we'll ask a lot of questions, and some of the questions seem kind of strange, like how much caffeine do you drink? Because if you're drinking a lot of caffeine and you're peeing frequently, well, that just might be the answer right there. But once we go through all those questions, and some of those will sound familiar based on what we've already talked about tonight, the physical exam, and like I said, nobody's getting one tonight, but a digital rectal exam is the hallmark. And with a digital exam, we can't completely rule out cancer, and we can't completely rule in an enlarged prostate. As we talked about, we're not feeling the inside, we're feeling the outside of the prostate, but at least we can get an idea of how big the prostate feels. And we can also feel if there's symmetry to the prostate, any lumps or bumps on the prostate that would signify cancer or something else possibly going on. One thing we could do is check on the urinary output, so we can do a bladder scan. I know a lot of people on this webinar have had a bladder scan where we do a quick ultrasound of the bladder and calculate how much urine is left after you're done urinating. A healthy bladder should be able to empty well, and an unhealthy bladder and an unhealthy prostate generally don't empty as well. And that is part of what gives you the feeling that you're not emptying. We can also do a flow test. It's kind of a really cool device that looks like a funnel on a scale, but it'll tell us how fast your stream is coming out. When you go to the bathroom in a public place and somebody goes next to you and you can hear the urine splattering against the back of the urinal, his urine's coming out fast. And when 2 or 3 guys go and you're still standing at the urinal, yours isn't. But one thing we could do is actually quantify that in the office. So it's important to know, because what is slow to somebody might seem okay to somebody else. And this is a nice way that we can quantify and compare your prostate and your flow to other people's. Everybody that comes to my office gets an email, and then if you don't fill out the email, we'll do it in the office. The American Urological Association Symptom Index, or it's also called the International Prostate Symptom Score, with 7 questions. Frequent urination, urgent urination. Do you have to strain to urinate? Does it start and stop? How is your stream? Do you wake up at night? And in addition to those questions, the last question to me is the most important. It asks, if you have to live the rest of your life with these symptoms, how would you deal with it? And that's a scale of 0 to 6. I've seen people with a symptom score out of 35 with 22, which is pretty high, but they're not bothered by it. And I've seen people with a symptom score of 7 who are very bothered by it. It doesn't matter how many symptoms you have. I want to make you happy. I want to make sure that you're not bothered by something if we can avoid it. So those are the hallmarks of the exam. Of course, a PSA is also something that we'll generally run to make sure that we're not missing prostate cancer if it's there. So this is obviously the main topic tonight. If you have BPH, now that we know what it is, we know what it isn't, and we know what causes it, what can we do about it? And this is evolving, and luckily it's evolving. Like anything, it's nice when we can improve things over time with technology. So a few things you can do, and again, you could figure these out on your own, or sometimes the doctor tells you about these things. So you come to the doctor's office, we don't always just give medication and do surgery. We'll talk about things. So we talked about fluid and diet changes. If you're waking up a lot at night and you have a lot of urine in your bladder every time you wake up, limiting the fluid in the evening can decrease the amount of fluid you have, and you might sleep through the night. Or if you're going frequently during the day and taking a long trip, a lot of guys reflexively will not drink coffee in the morning or drink less water. And that will help decrease the frequency and the urgency of urination. Kegel and bladder retraining. In fact, we're doing a lot more with physical therapists these days. If you're leaking urine and you can't get to the bathroom in time, we can work on muscle strengthening exercises that will help give you a little bit more control. They're not going to reverse the cause, but they're going to give you more control and decrease some of the symptoms. A lot of guys, and pretty much every guy with every condition pretty much starts with watchful waiting, which is waiting for something to get worse. And some guys progress slowly. Some guys don't progress at all. Most people do progress over time. But it's a nice way to avoid going to the doctor with watchful waiting. You know, when you come in, we talk, and if BPH is diagnosed, the first thing that most people think about, and traditionally what we always thought about, are BPH medications. And we're going to talk about these obviously more in depth, but the BPH medications are really nice because it's easy. It's not a permanent thing, which is good and bad. But you know, we'll get into that in a little bit. But these other two right in the first line therapies are newer procedures, and you know, kind of revolutionary. And you know, there have been minimally invasive office procedures in the past, but they tend to be short-lived and they tend not to work very well. We'll go into more depth on Resume and the permanent implants in a bit, but you know, kind of revolutionize the way we're treating BPH. And if you look to the right, which we'll talk about obviously more as well, we have two minimally invasive surgical under anesthesia procedures, one being the Greenlight laser and the other being the TURP, AKA the Transurethral Resection of the prostate, AKA the Roto-Rooter procedure. And then we can also do, there's a surgical knife, it should look like a robot in 2021, but the prostatectomy, where we remove from the inside. It's more of a major surgical procedure for extremely large glands, where you can remove that whole area of the adenoma that's growing. So the capsule of prostate remains intact, but everything that's blocking, we kind of remove it. As you can see on the bottom here, it goes in order from less to more invasiveness. But interestingly, I wouldn't necessarily say that correlates with less to more success and better treatment response. So we don't always need to be the most invasive to get the best response. So alternative medications, this is Boston Scientific's slide, and I'm going to point out that no dietary supplements or these kind of agents is recommended for the management of lower urinary tract symptoms secondary to BPH by the FDA. Things like saw palmetto, Urtica, Diocia, horny goatweed, which is my favorite one to say. I will say, however, you know, some guys get on super beta prostate or one of these other supplements and have a great response. So while they're not FDA approved, they're not really FDA regulated. You know, as long as you know you don't have cancer, a lot of people like to try those supplements, and you know, they might work for you. And if they do, that's wonderful. It's another line of therapy that you can have. Watchful waiting, as I mentioned earlier, you could exercise, You could limit evening fluid intake, some dietary or behavior modifications. You can change what time you take medications. If you're on a water pill, you can take that in the morning versus the evening, so you're not up at night. It can work. It can help. If your issue is waking up at night, you limit your fluids and you sleep through the night, it can help. And, up to 20%, 19% in this paper here that they're referencing, 19% say they're satisfied with the changes. And if you're satisfied, that's great. Again, if these are bothering you, we want to treat them. If we can get you to a place that you're not bothered, you don't need to go into any maximally invasive or even minimally invasive surgical treatment. But as we talked about, most people's prostates tend to grow more. And when they do, the first thing that most people start on are medications. And there's a lot of reasons for this. First of all, if they don't work, you can always stop them and do another one. They tend not to cause any permanent issues for the most part. The first medication we typically use are alpha blockers, things like the name Flomax or tamsulosin, alfuzosin, uroxetrol, terazosin, doxazosin. There's a lot of different ones, and we're in the third generation of these. So the tamsulosin, the alfuzosin, the silodosin, that's kind of the third generation. The first generation were great drugs for blood pressure because they were very general, and these alpha receptors are in the blood vessels and in the prostate. So the first drugs were used as blood pressure drugs, and some guys seem to pee better. So they worked on getting more specific drugs. And terazosin was actually developed locally here at Abbott. It was the second generation of drugs that are a little bit more specific to the prostate. Now, what does that mean? Well, the potential side effects of these drugs, you can get a drop in blood pressure, especially when you go from sitting to standing, called orthostasis, because they're affecting the blood vessels as well. When the blood vessels are affected, they're more relaxed, which is good for blood pressure, but they can't squeeze up as tight as you need when you go quickly from sitting to standing. You get a little bit of lightheaded. Some people get some fatigue. A very common issue, especially with Flomax, is what's called retrograde ejaculation, which doesn't sound bad. It sounds bad, I guess, but it just means that less semen's coming out when you have an orgasm, and little to no semen. And while it doesn't sound like it's a big problem, it certainly makes your orgasms feel less good, and we don't want our orgasms to feel less good. So that's a very common reason that people will stop these medications. Furthermore, you could have interactions with other medications. So these are prescription. Your doctor needs to know all the medications that you're on, so we can make sure that you won't have any higher risk of a side effect than you need to. Now, I'm hoping that my patients aren't like this, but 71% of patients stop taking this medication within a year. Why do they stop? Well, they got some benefit, but maybe not enough. They got a benefit, they forgot how much they benefit, they stop it, and they choose not to get back on, or commonly side effects of the medications. It's nice because you don't need general anesthesia, you don't need any permanent implants, and there's no risk of surgical retreatment because you haven't had a surgical treatment to begin with. There's another class of medications as well called 5-alpha reductase inhibitors. Proscar, aka finasteride, and dutasteride are the two medications in this class. These are a mixed bag. What these do, unlike the alpha blockers, which directly just relax the prostate, 5-alpha reductase inhibitors will actually shrink the prostate, which is great. So by shrinking the prostate, you're actually opening it up more permanently. It blocks the conversion of good testosterone to a more potent form of testosterone called dihydrotestosterone, but it's more potent, but only acts in certain places. This is the kind of thing that guys like me go bald over, right? Too much dihydrotestosterone, and that affects the hair on your head. Unfortunately, not the hair on some other places on our bodies. We would like to reduce this, and it's good to reduce this. And in fact, some big studies have shown combinations of alpha blockers with these 5-alpha reductase inhibitors decrease the need for surgery over time. We are kind of using them a little bit less over time as we have better surgical treatment options for the reasons on the right side of the slide, the potential side effects. Well, there's a couple of good side effects. I'll talk about those first. First, it could cause hair growth on the head. Propecia is another name for finasteride, and it can cause hair growth on the head, which is a great side effect to get. It lowers your PSA level by approximately 50%. So let's unpack that a little bit. If you have a PSA of 4, your PSA should go after about a year to 2. It doesn't mean that your PSA is actually 2. Your doctor is going to double it in their head to, say, okay, his PSA is actually 4. But it does do a couple of things with prostate cancer. So as long as we correct for the finasteride, it's okay. We know it's actually 4. It actually does lower your risk of prostate cancer as well. So that sounds great. So it's about a 25% reduction in risk of prostate cancer. And when this drug was first coming out and very popular, there were plenty of doctors who, for guys at high risk of prostate cancer, would write it to help prevent prostate cancer. Well, further studies have shown that it does reduce your risk of prostate cancer, but those who get prostate cancer while on this drug have a slightly higher risk of a more aggressive variety of prostate cancer. So not as low risk and something that might need to be treated. So it's a mixed bag as it relates to prostate cancer. It's something you have to be cognizant of. In addition to those side effects, the big side effects that people get and don't like from this drug, we're modifying testosterone, as we talked about. Well, that can cause erectile dysfunction, lowered sex drive, and no ejaculation. The prostate's just not making as much and shooting out as much fluid. And it could cause some breast enlargement as well. If you're a guy that gets these side effects, you certainly want to stop the medication. And first of all, the side effects are pretty bothersome to your life. But second, if you have these side effects for a long period of time, they can become irreversible. So we don't like that. And that's one reason now that since we have some better surgical or procedural treatments, we're not writing this medication as much because those side effects can be pretty bad. Now, on the bottom left, as we get to surgical, this will show a difference. Obviously, there's no general anesthesia and there's no permanent implants. So I think we're going to get to why we're here today. And again, you can see it's on every slide. Boston Scientific is the group that put together this talk. And, again, I appreciate it to be able to reach out to everybody so easily and give you all this information. They produce the equipment for 2 different surgical options for BPH. I will tell you that we're going to talk about both of them. And you'll see that even though Jack and Scott and I don't know who else from Boston are on the phone or on the webinar today, I'm going to tell you what I honestly think about both of their techniques. And one of them you're going to hear is not my favorite. So yeah, I'm not here just to shill things for Boston Scientific. I'm trying to give you good information. I just want to point that out and be as transparent as possible. So what is Rezum water vapor therapy? Well, it is, I'll read, a non-surgical outpatient therapy that uses the natural energy stored in water vapor to shrink excess prostate tissue. I've told a couple of you this story. When I was in my residency, my chairman called me and I was in the middle of cooking dinner. One of my hobbies is cooking, and I was making pasta that night. And he calls, and he's, the 75-year-old professor from Yale. And when he calls, I answered. I answer the phone. I have the pot of hot water with pasta in my hand. I put the phone to my ear and I'm pouring it out. As I'm doing it, I realize that something's not right, and the steam is coming up, and I feel it like burning my hand. As a surgeon, that's a really bad thing to have happen. I feel it burning my hand, and I'm on the phone with him. I can't drop the phone because he's the chairman. So I had it burn my hand. It was probably about a full second. It seems like a minute, but it was probably a full second before I can grab my hand away. And in that second, I got some pretty deep second-degree burns on my hand. And luckily, I was able to rehab it and get it better, and it looks great today. But in 1 second of steam from that water boiling the pasta, I burned the heck out of my hand. And so there's a lot of energy that we can store in water with bringing the temperature up. So that's what Rezum does, is it uses the energy in water to shrink the prostate and shrink that excess prostate tissue. When I first heard about this, I actually got a presentation from the original guy who developed this in Minnesota. And I kind of was holding in my laughter. I said, we're going to use steam to treat somebody's prostate? This is ridiculous. I'm never going to do this. 5 years later, I'm talking to you guys about this. The reason is it just really works. So there's potential side effects with any treatment. And on the right side of the screen, you can see a few of them. And we talk a little bit more about them. But, you know, during the procedure, obviously, we do everything we can to minimize discomfort. We give you some oral medications. We give you a nerve block through the prostate. We put some numbing medicine in the urethra, and soon we'll even have some laughing gas in the office that we'll be able to give to make it even better. But certainly the procedure itself, you will feel some things. It's really, for most guys, not too bad. It doesn't sound like a ringing endorsement, but I'll tell you, it's not too bad. For me to tell you that I'm going to put a camera in your penis and it won't feel badly at all, you guys will pick out pretty quickly that that's not the truth. But it's really not too bad. The procedure itself, the biggest downside compared to some of the other procedures, and I think it's a downside that's worth going through, are the first few weeks. And we're going to show you a quick video. But in the first few weeks, you can have some burning with urination, some pain with urination, frequent and urgent urination, some blood in the urine and blood in the semen. And the bleeding is much lower with this than some of the other procedures, except for the permanent implants. But some of the frequent and urgent urination can be a little bit worse than some of the other ones initially. The good news on the bottom left here, no general anesthesia, no permanent implants. So if you need something else done on your prostate, you could pretty much have anything else done because you don't have pieces of metal and suture sitting in your prostate. I really want to highlight that last thing, the 4.4% surgical retreatment through 5 years. We'll show you kind of the stats on the other surgical treatment options. And this is as good as anything and better than it's kind of the gold standard, which is the TURP. We'll talk about the UroLift in a second, but that's why I stopped for the most part doing UroLift. I had too many patients were doing great for a year, and then a year, 2, 3 years later, I said, you know, I feel like I've never had anything done. And you look back and the prostate's just really just kind of occlusive again. And with Resume, you know, you might see a point regrowth in 1 or 2 areas, which you can easily treat. But for the most part, that prostate is open and you actually got rid of tissue. So it does what it says it's going to do. So we'll get to the video in a second. Just want to point out during the video, before you have the capsule here of the prostate on the outside, which we're not trying to get rid of, that stays. But the adenoma, this big part on the inside, which causes obstruction of the urethra, what we want to do is treat that so this tissue goes away and then you have a bigger opening. So I'll take a second to play this video here.
In water vapor or steam. Clinical studies support that Resume relieves BPH symptoms safely and effectively, eliminating the need for BPH medications, while also preserving sexual function. During each 9-second treatment, sterile water vapor is released throughout the targeted prostate tissue. When the steam contacts the tissue and turns back into water, all the stored energy is released, causing the cells to die. Over time, your body's natural healing response absorbs the dead cells, shrinking the prostate. With the extra tissue removed, the urethra opens, reducing BPH symptoms. Most patients begin to experience symptom relief as soon as 2 weeks, and maximum benefit may occur within 3 months.
So when I told you my story about burning my hand, I said it was probably a second. This is 9 seconds that we're putting the steam under pressure directly into the prostate. So it really does a good job of causing those cells to die off, for lack of a better term. Wow, look at that. We can also look at these things. Let's go to the next slide. How did that come up on my, wow, that's interesting. There we go. All right. So 9 seconds is a long time to be steam cleaning something. And so it really does a good job. But as you'd imagine, the initial response of the body is inflammation. When you get burned, your skin gets inflamed. It's the same with the inside. So that's why initially you'll have a little bit increased frequent urgination and some urgent urination, some burning. A fair number of my patients will have some significant benefit by 2 to 3 weeks. A lot of guys takes a little bit longer. It could take 4, 5, 6 weeks before you're starting to really start to benefit from it. The interesting thing is almost everybody really does benefit in the end. And then almost everybody says, yeah, there were some bumps in the road, like with any surgery, but it was worth it. And in fact, 97% of patients in one survey would recommend Resume to a friend. All right. So another minimally invasive procedure that's out there is called the prostatic urethral lift. And I know Boston didn't put that down, but it's called the UroLift. And they do a very good job of marketing to doctors. They do a very good job of marketing to patients. And it does a fairly good job in a small subset of patients, in my opinion. Clearly, there's a need and a use for it. I just feel that from an overall utility perspective, it's not as good as some of the other options. So what is it? It's a non-surgical outpatient procedure, just like the Resume, that utilizes permanent implants to lift and hold the enlarged prostatic tissue out of the way so it no longer blocks the urethra. So if you can imagine, the prostate is enlarged. It's basically a suture with two barbs at the end that pulls that prostate open. Well, one, in my opinion, the biggest issue with that is when it pulls it open, first, you're putting a foreign body in there. Second, as the prostate grows and you have 4, 6, 7 little points of things holding, well, the prostate can grow around it. And that's kind of when they fail, what it looks like is that you can't see these anymore. The prostate's grown around it. Potential side effects of this, similar to the Resume, you could have some pain when you urinate, some blood in the urine, a urinary frequency. Some people develop some pelvic pain from the barb either going into the bladder or in the pelvis where it's supposed to go. You can develop stones potentially on these if they don't kind of what we call epithelialize, which means get covered up. Again, the nice thing about this procedure, there's no general anesthesia. It is a permanent implant. So if you ever need anything else, it limits some of the other options down the road. As I alluded to before, my biggest issue with the UroLift is the retreatment rates. At 5 years, a new study showed a 13.6% surgical retreatment. But when you add medical retreatment, you're topping off at about 30% of people that are either back on meds or have surgery at 5 years. And that's less than half of that for when you look total between surgical retreatment and medical retreatment with the Resume at 5 years. And to me, if I'm going to do a procedure on my patient, I want them to do really well. And I want them to do well for a long time. This isn't an annuity for me to keep operating on you every 3 years. I want to have you do well and live your life and not see me, go see your friends. So that's the reason that I've soured on the UroLift. And, I've done a fair number of them. In fact, I was preferring it initially to Resume because it works a little bit quicker, but I take a couple of weeks longer for it to take effect after you've been dealing with something for years, and a longer treatment benefit. So there's a couple of surgical options that are under anesthesia. These are still minimally invasive treatments, but they're less minimally invasive than the Resume and the UroLift. The first is the Greenlight laser therapy. And again, as I mentioned, this is also a Boston Scientific product. And what it does is it gets rid of tissue from the prostate using a laser. It's an outpatient procedure almost all the time, and the laser actually vaporizes the tissue. So the tissue just gets vaporized. You don't get big chunks of tissue out afterwards because it just vaporizes in the water and you let the water out. Now, similar side effects to these other procedures, some pain or discomfort when urinating, blood in the urine, inability to urinate or infection and frequent and urgent urination. It sounds like a broken record, but all of the procedures have similar side effects. All of the procedures, when I do them at least, for the most part, I put in a catheter. Rarely do you not need a catheter for any of these procedures. So they all have some of the same downsides. What you really want to look at, what are the upsides? Well, with the Greenlight, you need general anesthesia. Luckily, there's no permanent implant, and it works reasonably well, a surgical retreatment rate of 4.8%. And again, that's surgical retreatment rate at 5 years. I prefer, if I'm going to do something under anesthesia, the transurethral resection, but certainly the Greenlight is a good option for some guys. And depending on the size and shape of your prostate, it could be a great option. We have another little animation. Again, being a Boston Scientific product, we get more animations for those. But again, you're going to see this adenoma tissue kind of vaporized and be opened up. So let me play that briefly. was enough of that music. I hope you all enjoyed that music and danced a little bit. But you can see that laser was opening up the prostate. And again, it can work very well. I prefer, if I'm going to do something under anesthesia, and sorry to the host of the meeting, I prefer the transurethral resection of the prostate. This has been around the longest. It's the gold standard. It's a surgical, but generally now outpatient procedure. They use a heated wire. We call it a loop to shave tissue from the prostate. And as I've explained it to my patients in the past, it's kind of like when you go to a Euro restaurant and they're slicing that Euro meat off of the spit one by one. These kind of look like little pieces of Euro meat. Sorry, but they do. And that's kind of what it is. So we're just creating a crater in the prostate by shaving it out. And again, you're going to look at the potential side effects similar to the other ones. You have a catheter. Almost everybody goes home these days. 10 years ago, everybody stayed in the hospital for a night or two with bags of fluid hanging and irrigating out blood from the bladder. We generally don't need to do that anymore. Again, you need general anesthesia and the cost and risk associated with general anesthesia in the surgery center or hospital. You don't have any permanent implants. And the surgical retreatment rate is about 5.8% at 5 years. Again, that's pretty much similar to Resume and Greenlight laser, and obviously much lower than the UroLift. One potential reason that's a little bit higher is we tend to do these on the biggest prostates. We've always been doing transurethral resection, so we're still doing them sometimes on a little bit bigger prostates. But for the biggest of the big, the largest of the large, we still have one other option. It's called simple prostatectomy. And that's an inpatient procedure where we either use an open incision or the surgical robot to remove that blocking tissue out. And when we use the robot, we actually make an incision into the abdomen, then through the bladder to remove it. So there's a higher risk of bleeding from the procedure. There's a risk of blood transfusion. There's a risk for major surgery, intestinal damage, sepsis. Everybody who gets the prostatectomy, simple prostatectomy, has retrograde ejaculation. 80% of people who have a TURP get retrograde ejaculation. Similarly with the Greenlight, with the Resume, it's only about 5 to 10% of people who get retrograde ejaculation. So your orgasms will still feel reasonably good. They might not feel the exact same as you've had in the past, but generally they feel better than if you had one of the other procedures. Also, sexual dysfunction, erectile dysfunction with the simple prostatectomy and with the TURP could be up to 10%. And we're not really seeing that with the Resume procedure. Insurance coverage. This is a disclaimer. It's the responsibility of the patient to contact your insurance. You know, in our office, we have a team that does prior authorization with your insurance to make sure they do cover it. They might not be able to find out exactly what your out-of-pocket will be from it, but we will work with you to make sure that it's covered. I don't want anybody to have a procedure and then get stuck with a bill. Interestingly, though, if you have a 20% out-of-pocket, this procedure is the least expensive. You don't have the hospital fee. You don't have the anesthesiologist fee. And the UroLift is significantly more expensive. And if you're paying a percentage of the total bill, Resume is actually going to be the least expensive while working, I think, extremely well. So that's an interesting thought. So to summarize, and I want to get to some questions, so I'm glad we have time for that. To summarize, what is the prostate? How does it work? We talked about that. It's there to help you have kids, and after that, it's there to cause problems urinating and cause cancer. It's called a BPH when it's enlarged, and we can watch it. We could try some medical therapies, and then, I mean, some guys now are coming in saying, I don't want medicine. I want the Resume. I've heard about it. My friend had it. I read about it in the news. I want the Resume, and they're getting a more permanent solution right from the beginning. They're not suffering with the side effects of the medication, the cost of medication, and just fixing it. That way the bladder is not blocked and it doesn't have to be blocked for longer. And this is what I was saying with the change in the paradigm. You know, when all we had were the under anesthesia surgical procedures, everybody was on meds until they really didn't work anymore. Now we're moving it up, and people are getting happier more quickly and staying happier longer. So obviously this is a 1-hour overview of these things. Please, if you're having symptoms, make sure it's not prostate cancer. Please talk with your primary care doctor or your urologist. If it's me, great. If it's not me, talk to them. If you want to talk to me, I'm here too. But you know, when your only tool is a hammer, everything looks like a nail. And when the only thing we had was a TURP, well, everybody got a TURP. Now we've got a lot of different options, and there's no one size fits all for this. So what I want to make sure is when we talk about this, we're not coming in and saying, okay, let's prepare for a resume. We're coming in and say, let's find what works best for you to treat your BPH, whether it's medically or surgically, that works with your lifestyle and your goals and what you like to do. And we can usually find a solution that fits you pretty well. So I know there's probably some questions, and Jack and Scott, I think you have access to read those. Is that true?
Yes, that's correct.